The bad news is that time flies. But the good news is that you are the pilot. So if you lose any opportunity, today by chance you have thought that you have to finish this match, you have to do this, you have to do that, and by chance you are not able to do that, when do you have the next opportunity? The next moment. Every moment you have a new opportunity. So don't waste time, don't miss any opportunity. Time once gone will not come back again. It will be only in your memories that you'll be able to remember it. So make yourself proud of yourself. Be the pilot and take your life where you want to go. So now we start with the third part of audiology, and that is tympanometry and stapedial reflex. So now whenever a patient comes to you in the OPD with a complaint of hearing loss, so what is our aim? Yes, to localize whether this is a disease of external ear or middle ear or inner ear. We know any part of the ear, any condition can lead to hearing loss. So first we want to localize whether it is external ear, middle ear or inner ear. So this patient is sitting in front of you. Patient is telling you, doctor, I am having hearing loss. I cannot hear properly. So what is the first thing that you do? Yes, the first thing is you examine the patient. You examine the ear of the patient. You have a look at the ear of the patient. You do not immediately jump on doing some test. The first thing is you examine the patient. So you examine the ear of the patient, and what you see is there is some disease of the external ear, or there is some disease of the tympanic membrane, maybe a perforation of the tympanic membrane or any condition of the tympanic membrane, which you can just have a look and you can diagnose. So then what do? Do you go for any test? No, all these tests that we do is to help us in diagnosing. When we have already diagnosed, we don't need to go for any test. We have diagnosed, treat the patient. So what you do is you have a look at this patient who has come to you with hearing loss, and you examine the ear. What you see is that the pinna is normal, external auditory canal is normal, tympanic membrane is appearing absolutely normal. So now where have you localized the lesion to be? The patient has hearing loss. The external ear has been ruled out. The pinna, external auditory canal, tympanic membrane absolutely appears normal. So now where do you think is the lesion? Yes, so now we are in a dilemma. It can be either middle ear or it can be inner ear. So now is when you take up your tuning fork, you do the test, and you find out whether it is a conductive or a sensorineural hearing loss. That is what we have seen in the previous modules, how we do the tuning fork test, how we find out whether it is a conductive or a sensorineural hearing loss. So you do the test and you find out that this is a conductive or a sensorineural hearing loss. The moment you see it is a conductive hearing loss, you know that the problem is in the middle ear. So if it comes to be a sensorineural hearing loss, you know the disease is in the inner ear. So by the tuning fork test and by the audiogram, you have confirmed that this patient has a conductive hearing loss. So you have localized the lesion now to be in the middle ear. Now, is that enough? In the middle ear, is there only one condition that can be and that can lead to hearing loss? No, there can be many conditions. For example, what are the conditions of the middle ear that we think of when the tympanic membrane is appearing more or less normal? Yes, there can be either discontinuity of the ossicular chain. There can be either ossicular fixation. Yes, or there can be fluid collection in the middle ear. So the management of each of these conditions is different. So we need to first localize out of these three which is the patient having, so that we can treat the patient accordingly. So now our next aim is, when we have localized the disease to be in the middle ear, is to find out which disease of the middle ear is the patient having, so that we can treat the patient accordingly. So now the test that we do to serve our purpose now, that is to find out the condition of the middle ear when the tympanic membrane is appearing normal and the patient has a conductive hearing loss. This test is what is known as impedance audiometry. It is known as impedance audiometry. Impedance audiometry. Why impedance? What is the meaning of impedance? Yes, one of the function of the middle ear is impedance matching. Match the resistance of the flow of sound from the middle ear into the inner ear, from air into the liquid. So this is what is known as impedance audiometry. And impedance audiometry has two parts. The first is tympanometry. And the second is stapedial reflex. We have heard of stapedial reflex so many times, no? Stapedial reflex in anatomy. So now we'll see what exactly the stapedial reflex is, yes? So this is to test tympanometry and stapedial reflex. First, let us see what tympanometry is, then we will come to the stapedial reflex. Now let us see how we do tympanometry. Now in this test, what we do is we pass a probe into the external auditory canal. This probe has 3 openings. Through one opening, a sound of 220 to 226 Hertz is given into the external auditory canal. So depending upon the condition of the middle ear, some sound passes, some sound gets reflected back. The reflected back sound is picked up by the second opening. Now, what's the meaning of this? That depending upon the condition of middle ear, some sound passes into the inner ear, some sound gets reflected back. Yes, we know that the function of the middle ear is to conduct the sound from the external ear to the inner ear, which means that the better it is at its function, the more good it is at its function, the more of the sound it is letting go into the inner ear. It is transmitting to the inner ear. So, if more of sound is getting transmitted into the inner ear, less sound will get reflected back. Which means that if the second probe, which is picking up the reflected back sound, is picking up very little sound, it is an indication that most of the sound has got transmitted. It is an indication that the middle ear is functioning properly. Whereas if most of the sound that has been given is reflected back and it is picked up by the second probe, it is an indication that middle ear is not functioning. It is not transmitting the sound into the inner ear. Now what the third probe does is it changes the pressure of the external auditory canal. So what we are doing basically in this test is that we are changing the pressure of the external auditory canal and we are seeing the movement of the tympanic membrane. The movement of the tympanic membrane is what is known as compliance. It is known as compliance. Compliance. We know meaning of compliance. Compliance is opposite of resistance. So the ease of movement of tympanic membrane is compliance. So do the conditions of middle ear alter the mobility of the tympanic membrane? Will, because of conditions of middle ear, disease of middle ear, the tympanic membrane mobility be hampered or accelerated? Yes. If there is ossicular discontinuity, what will happen to the mobility of the tympanic membrane? It will increase. There is no resistance now. Ossicular chain has got discontinued. Whereas if there is fixity of the ossicular chain, what will happen? The mobility of the tympanic membrane will reduce. If there is fluid in the middle ear, again the mobility of the tympanic membrane will reduce. So very good. If the ossicular chain is dislocated, then the tympanic membrane is moving more, which means if the tympanic membrane compliance we are seeing is increased, it is an indication that there is ossicular discontinuity. But if the tympanic membrane is moving less, then it can be either ossicular fixation or it can also be a eustachian tube obstruction. Fluid in the middle ear, yes or no? Why does fluid collect in the middle ear? Because of eustachian tube obstruction. So it can be either a ossicular fixation because of which the tympanic membrane is moving less, or it can be fluid in the middle ear because of eustachian tube obstruction, because of which the tympanic membrane is moving less. How do we differentiate? The management of both of these is different. So how will we find out whether it is a ossicular fixation or a fluid in the middle ear? Yes, for doing that, what we will do is we will find the eustachian tube. We will see how the eustachian tube is functioning. If the eustachian tube is functioning normally and still the tympanic membrane is moving less, it is an indication that tympanic membrane is moving less, not because of eustachian tube obstruction, but because of ossicular fixation. If the tympanic membrane is moving less, at the same time eustachian tube is obstructed. So we will know that in this patient there is fluid in the middle ear because of which the tympanic membrane is moving less. So how do we find out the eustachian tube function? What is the function of the eustachian tube? Yes, it ventilates the middle ear, and by ventilation of the middle ear, it maintains the middle ear pressure. So the second thing that we are measuring here is the middle ear pressure. The middle ear pressure, and this middle ear pressure is an indication of eustachian tube function, because this will help us to differentiate whether it is eustachian tube obstruction leading to serous otitis media, leading to fluid collection, or it is the tympanic membrane is moving less just because of ossicular fixation. Now, how by changing the pressure in the external auditory canal can we find out the middle ear pressure? Now just look here. What we do in this test is, we change the pressure of external auditory canal from minus 400 to plus 200. Okay. Now, whenever the pressure of the external auditory canal is more means it is positive, which means that the pressure is more than what? More than the middle ear. So pressure here is negative. So what will happen in this case? What will happen in this case? The pressure, more of pressure in the external auditory canal will push the tympanic membrane inside. When the tympanic membrane will get pushed inside, the ossicular chain mobility will get restricted, sound transmission will get restricted. Now, let us take the opposite scenario. What is the opposite scenario? Yes, that the pressure in the external auditory canal is negative and the pressure in the middle ear is more. The pressure in the middle ear is more, pressure in the external auditory canal is less. In this case, what will happen? In this case, the more pressure of the middle ear will push the tympanic membrane out. Again, the ossicular chain will get stretched, which means it is not able to freely move. It is stretched and it is moving. So again, the transmission will decrease. What we are seeing here is that whenever the pressure is different in the external auditory canal and in the middle ear, the pressure is not the same. What will happen is either the tympanic membrane will be retracted or the tympanic membrane will be pushed forward and the proper transmission of sound will not happen. In other words, for proper transmission of sound to occur from the external ear into the inner ear, the pressure in the external auditory canal as well as in the middle ear should be same. So the pressure here, when this pressure and this pressure is the same, only then there will be no pressure on the tympanic membrane and it will no pressure on the ossicular chain, no stiffening or no tightening or no stretching of the ossicular chain, and it will function maximum, which means that when we are changing the pressure from minus 400 to plus 200 and we are giving a sound, we are picking up the reflected back sound, and what we are seeing is at what pressure of the external auditory canal the transmission of the sound is maximum, which means that the least amount of sound is getting reflected back. That pressure of the external auditory canal, it means that that is exactly the pressure of the middle ear. Because only when the pressure of the external ear and the middle ear is exactly the same, only at that time the maximum transmission of sound will occur. So whenever the maximum transmission of sound is occurring at whatever pressure of external auditory canal, we take it for granted that at that particular moment maximum transmission is occurring because the middle ear pressure is the same as external ear pressure. So now we know the middle ear pressure. So this is how we find out the middle ear pressure. So have you understood when you will do this test? Yes. So the first thing we need to know is that in which patient we are going to do this test. So we are going to do this test when we have localized by the other test, by the tuning fork test and by the pure tone audiometry that this patient has a disease in the middle ear. But because the tympanic membrane is intact, we are not able to find out what the disease in the middle ear is, whether it is discontinuity, fixation or fluid. Yes. So what is the indication of tympanometry was a question of your exam. It is done to find out the condition of middle ear with intact tympanic membrane. Intact tympanic membrane. So which means that whenever you have a question something like this, that a child or whatever age, a 6-year-old child is brought by parents with a complaint of decreased hearing. So there is decreased hearing. So the moment you see decreased hearing, the complete picture of the ear comes to your mind, external ear, middle ear, inner ear. Now you want to localize. Yes. So since past 1 week on examination, EAC looks normal. So you have ruled out external auditory canal. Tympanic membrane is intact. In appearance in both the ears, the appearance is given below. Now here I have not given because we have not yet started with the diseases. So yes, when the tympanic membrane is also intact in appearance and the bone conduction is better than air conduction. Bone conduction is better than air conduction means, yes, it means Reni's is negative. Reni's is negative, that is the indication of conductive hearing loss. So that indicates that in this patient, in this child, the child has a conductive hearing loss. Tympanic membrane is intact. So now where is the disease? You have localized. It is in the middle ear. Conductive hearing loss, so middle ear. Tympanic membrane is intact, so it has to be. Now you want to find out what the disease in the middle ear is. So how do you find out that disease? Now to find out, localize, we will go for tympanometry. How is this test done? So here I already told you that we pass a probe in the external auditory canal, and through that sound is given, reflected back, and immediately the result you get in the form of a graph. So what is this giving you the hint? Is this a subjective test or an objective test? Is the patient's cooperation required? Not at all. You just put the probe, you give a sound, and you get the result in the form of a graph. So this is an objective test. This is the objective test. Yes, and nowadays it can be done with a very easy handheld device. Immediately you put it in the ear, give the sound, and you get the result in the form of this graph. So the result that you get is in the form of a graph, and this graph is what is known as tympanogram. This is known as tympanogram. So let us see that whenever we have done this for any patient, what is the result? How do we read this tympanogram? So here I told you earlier we are measuring two things. Can you tell me what two things we are measuring? Yes, one is the compliance, that is the mobility of the tympanic membrane. Second is the middle ear pressure. Middle ear pressure is an indication of the eustachian tube function. So the compliance, normal compliance is between 0.35 to 1.45 ml. And the normal middle ear pressure is between plus minus 50. Plus 50 to minus 50. This is in adults. And in children, it is more of negative pressure because the eustachian tube many times is not functioning very properly, 100% properly. So it is minus 150 to plus 50. This is in children. Moreover, for practical purposes, just remember that in between plus 100 to minus 100, this is a normal value of the pressure that we take, millimeters of water. Now let us read this tympanogram. So here what we are seeing is that if the middle ear pressure is normal, that is an indication that what is normal? The eustachian tube is normal. So if the middle ear pressure is normal, at the same time the compliance is also normal. So that is what is called as the A type of curve. So A type of curve means normal middle ear. So you must be thinking that here the compliance value is not given. How can we say that it is normal? Yes, just remember that this value is usually not asked in your exam. And when you have to read the tympanogram, a rough idea is if this graph, yes, if the peak of the graph is somewhere in the middle of this graph, it is more or less normal. Yes, for example, here it is falling, this here is the height, it is falling somewhere in the middle, so that is normal. If you can remember the value, that is wonderful, that is very nice. Now if the middle ear pressure is normal, that is the eustachian tube is functioning normally, but the compliance is increased. Just see here, it is going up so much. Yes, so this is what is known as the AD type of curve, and the D itself tells you that why is the compliance increased? Yes, the compliance is increased means there is discontinuity. So this D stands for discontinuity. Ossicular discontinuity. Now, if the middle ear pressure is normal means eustachian tube is normal, but the tympanic membrane is moving very little. Tympanic membrane compliance is very little. Just see here, as it is here, the tympanic membrane mobility is very little. So, why has this happened? Yes, if the tympanic membrane mobility is little, then we have to rule out two things. One is the ossicular fixation, the other is the fluid. Why is this not fluid? Or why is this fixation? Yes, because the middle ear pressure is normal. If the middle ear pressure is normal, it means eustachian tube is normal. So that is what is known as AS type of curve, or S stands for sclerosis or stiffness. So this is seen in autosclerosis. Autosclerosis is the most common ossicular fixation. So this will be seen in ossicular fixation. Or whenever the mobility of the tympanic membrane is less with the middle ear pressure being normal with the eustachian tube being normal, for example, in tympanosclerosis. What is tympanosclerosis? In tympanosclerosis, there are calcium deposits on the tympanic membrane. So that stiffens the tympanic membrane and the mobility of the tympanic membrane gets restricted. So either in ossicular fixation or in otosclerosis or in tympanosclerosis. Or in tympanosclerosis. So what we are seeing here is that whenever you see A, AS, AD, all have a common A. So common A indicates that the middle ear pressure is normal. The defect is only in the ossicular chain. In AD, the ossicular chain is discontinued. In AS, the ossicular chain is stiffened. So now if the middle ear pressure is negative, how do you know that the middle ear pressure is negative? Because the curve will now shift towards the negative side. So as we are seeing here, yes, if the middle ear pressure is negative, yes, the highest peak of the curve is towards the negative side, and at the same time, the compliance is also reduced. As you are seeing here, yes, the compliance is also reduced and the middle ear pressure is also negative. That is what is known as the B type of curve. So B type of curve, I have told you what is happening here. The pressure is negative. What does that give you a hint? Pressure is negative means, yes, the eustachian tube has got blocked and the tympanic membrane is moving less. The compliance is reduced. Why? Because of fluid. So B is an indication of serous otitis media or fluid in the middle ear. I have told you A, I have told you AD, AS and B. Now you tell me what is C. You tell me what is C. Yes, tell me the middle ear pressure. What is the pressure in C? Yes, very good. It is negative. So this is negative pressure. And how is the compliance? The compliance is more or less normal. Negative pressure, what does it tell you? Eustachian tube is blocked. Yes, eustachian tube is blocked, but the compliance, the mobility has not yet got affected, which means that the fluid has not yet collected. So this C type indicates that this is the early stage of eustachian tube obstruction. C type is early eustachian tube obstruction. Early stage of eustachian tube obstruction. Yes. So if any tympanogram is given to you in the exam, will you be able to diagnose by seeing the tympanogram what it is? Let me show you this. Yes, this upper graph, try to identify. Yes, so what we see is, we just have to see two things. One is the pressure of the middle ear, second is the compliance. So here, what is the pressure of the middle ear? Yes, this is, yes, it is falling, the peak is falling in between plus 50 to minus 50. So middle ear pressure is normal. Pressure is normal. And compliance, and I told you that many a times the marking is not done. Yes, of the compliance, the values is not given. So how you can just make out is the total length. Just see if it is falling somewhere in between. In between, yes. So the compliance is also normal. So what curve is this? What is your diagnosis? This is A-type curve. A-type curve means normal middle ear. Okay, now come to here. What we are seeing here is that the middle ear pressure is normal pressure. So eustachian tube is normal. And look at the compliance. It has reached the top of the graph. Compliance is increased. Tell me the diagnosis. Yes, it is ossicular discontinuity. That is a D type of curve. Tell me this. Yes, okay, first tell me the lower curve. Tell me about this. Yes, tell me the middle ear pressure here. Yes, we can see that the middle ear pressure is many times in the tympanogram, a box is made and this indicates the normal range of the middle ear pressure. So here what we are seeing is that the peak is towards the negative side. Peak is negative. So here the middle ear pressure is negative. That is indication that the eustachian tube has got obstructed. So here the middle ear pressure is negative. So eustachian tube has got obstructed. Yes, it's got obstructed. Now just see the compliance. Yes, the compliance, if you remember, it is normal between 0.35 to 1.45. You can just see that, okay, it is falling in between. It is somewhere around 1. Or what I told you is the easy way is just see the total length and see if it is falling somewhere in between. Somewhere in between. Then that is an indication that it is normal. So yes, this is also, it is more or less in between only. So this is also normal. So the compliance is normal. Compliance is normal. So what is this? Which curve is this? Yes, this is the C type of curve. What is C type of curve? The middle ear pressure is negative. Means eustachian tube has got obstructed. Compliance is still normal. It means that the mobility has not got restricted. Why? Because fluid has not yet collected. Now read the upper curve. Yes, can you see here? Where is the curve? Where is the curve? Yes, see this? This has become a flat line that you're getting. Yes, you're getting a flat line here. So, usually, what is the B-type curve? B-type curve is that the pressure is negative and the compliance is reduced, right? The pressure is negative and the compliance is reduced. This is something B-type. B-type is also known as dome shape. B-type is also known as dome shape. As we have seen earlier also. Yes, in this, did you see the B-type? How is it? Yes, this is dome shape. This is known as dome shape. But if the fluid is so much that there is so much of fluid that the tympanic membrane mobility is not possible at all, then what you will get is a further flattening of the B type of curve, and then it can turn to a flat curve. It can also become a flat curve. Now suppose here is a patient who has come to you with a complaint of decreased hearing. And the patient tells you that somebody in a road rage, yes, and following that I feel that I am hearing less. So you examine the ear and what you see is that there is a perforation of the tympanic membrane. Now this patient is asking you, doctor, I know that in the middle ear we have some small bones. So are they okay? You tell the patient that, see, your tympanic membrane has got ruptured, your eardrum has got ruptured. So he's asking you that, are the bones, small bones okay, or they have also got damaged? So now you think that, okay, the bones I have to check. Should you go for this tympanometry? Yes or no? What we are doing here in tympanometry is we are changing the pressure of the external auditory canal. Yes. So if there is perforation of the tympanic membrane, how will a change of the pressure and the middle ear and the external auditory canal be possible? No. So this test will not be possible at all. You cannot do this test when there is a perforation of the tympanic membrane. That is why the first thing I asked you is, when will you do this test? When the conductive hearing loss you have confirmed and the tympanic membrane is intact. By seeing the tympanic membrane, you are not able to find out what the disease of the middle ear is. If there is a perforation of the tympanic membrane, you will not be able to do pressure changes. This test will not be possible. Okay, if by chance you do this test, what will you get the result as? By chance you do the test. Yes, in perforation, patient is dead. What is the ECG finding? Tall T, inverted Q, flat what? Flat curve. Why flat curve? Because you're not able to do this test. So here, when you're not able to do this test, what will be the curve? You will not get any curve. You're not getting any curve means what are you getting? A flat line. So if you're getting a flat line, it can be either that the fluid is so much that the mobility of tympanic membrane is not possible at all, or it can be because of a perforation of the tympanic membrane. Perforation of tympanic membrane. Is that clear? Yes. So now you are going to fill this table for me. I'm just going to write down whatever you tell me. So you tell me and I will go on writing. Yes. So we have the middle ear pressure and the compliance, and this is what we are testing in the test of tympanometry. So A type of curve, middle ear pressure is normal. Compliance is also normal. A is all is well. A is all is well. Everything is good. Diagnosis is normal middle ear. What is AS? AS is stiffened ossicular chain. Yes, S is stiffness. So, or sclerosis. So middle ear pressure is normal. Eustachian tube is normal in ossicular fixation. Compliance? Tell me compliance. Compliance will be reduced. This is any ossicular fixation. Most common ossicular fixation is autostosis. So this is most commonly asked in your exam. In autostosis, tympanogram finding will be, or tympanosclerosis. Okay, AD is middle ear pressure, normal. In all A, the middle ear pressure is normal. The compliance, the mobility of tympanic membrane increased. This is ossicular discontinuity. B or dome, or it can also become a totally flat. Yes. So B or dome shape will be seen in, yes, the middle ear pressure here will be negative. and the compliance will be reduced. So this is serous otitis media or fluid in the middle ear. What is C? Middle ear pressure negative, compliance normal. So this is early eustachian tube obstruction. And what is flat? Flat can be nothing, yes? Nothing, no pressure, no compliance, and this can occur either in fluid or in perforation. Okay, so quickly tell me now, if there is fluid in the middle ear, what is the curve that you get? Yes, B type. Okay, if there is a B type curve, what is the pressure of the middle ear? Pressure of middle ear? Negative. What is the compliance? Again negative. If any patient, there is ossicular discontinuity, what is the curve that you get? AD. Okay, following decreased hearing, in a patient of decreased hearing of the right ear, Rinne's in the right ear is negative. Weber's is towards the same side. And on examination, the compliance, the tympanogram shows increased compliance and the middle ear pressure is normal. What is the diagnosis of this patient? Tell me. Yes, the middle ear compliance is increased and the pressure is normal. Yes, diagnosis is ossicular discontinuity. Yes, patient complains of decreased hearing of the right ear. Rinne's in the right ear is negative. The Weber's is towards the right. On examination, the tympanic membrane appears normal. And on examination, the middle ear pressure is negative and the compliance is also reduced. What curve is this? Middle ear pressure is negative and compliance is also reduced? Yes, that is a B type of curve. What is the diagnosis? Yes, serous otitis media. So these are the type of questions that are asked here. So this is one test of the eustachian tube function that we know, that is tympanometry, where we are measuring the middle ear pressure, and this is considered to be the best test for eustachian tube function. So do we know of any other test for eustachian tube function also? If I ask you that right now sitting there, can you test whether your eustachian tube is functioning normally or not? Can you do that? Right now, here itself, without any testing? Yes, you can do that. How can you do that? Yes, without any instrument to test. Yes, how can you do that? Yes, by Valsalva maneuver. Valsalva. What is this Valsalva? Do you know how to do it? Yes, all you have to do is you have to close your nostril and you have to blow, you have to breathe out. You have to exhale with your nostrils and your mouth closed. So what will happen in this case? What will happen when your nostrils are closed? When your mouth is also tightly closed? Yes, when you are exhaling, the air will go. Now it cannot come out from here, it cannot come out of here. So the pressure of air will build up and it will go through the eustachian tube into the ear. And you can see the eardrum popping out. Not only see, you can also feel. Yeah, so you can do it now and you can see, you can check now itself whether eustachian tube is functioning normally also. But one caution. If you are doing it, be sure that there is no infection of the throat right now that you are having. Because if you are doing this, along with the air, you will also be pushing the infection into the middle ear. So that you do not have to do. So this is what is Valsalva. Now, many of the times, patients are not able to do Valsalva properly. So then, how do you test is by this method, which is known as the Pulitzer test. There is this bag which is known as the Pulitzer bag, and instead of patient asking to increase the pressure of air in the nasopharynx where the eustachian tube opening is present, what you do is you actively do it with the help of this bag. So you ask the patient to close one nostril and through the other nostril you put the Pulitzer bag and you increase the pressure, and you see that by increasing the pressure, the eustachian tube, if it is functioning properly, it will transmit the air and you will see the popping out of the tympanic membrane. This is what is known as Pulitzer test. Another test we have is Toynbee test. Now what is this test is, you ask the patient to have a sip of water, and with a sip of water in the mouth, you ask the patient to close the nostril and swallow. So what happens by this is that when the patient swallows, yes, a negative pressure is created in the eustachian tube area, and that the patient will also report as if the tympanic membrane he felt is getting pulled in, or you can see it by otoscopy, or this can also be, the middle ear pressure can also be measured during this time by tympanometry. This is Toynbee test. Now a test which used to be done quite in old times is the eustachian tube catheterization, but yes, this is still asked in your exam. And what is this eustachian tube catheterization is, you pass the eustachian tube catheter. This is what is instrument which is known as eustachian tube catheter. Just note here, it has got a ring. And why does it have a ring? This ring is in the same direction as the point of this catheter. What is done is that this eustachian tube catheter is passed through the nostril. So when the eustachian tube catheter is passed into the nostril, where the tip is pointing, we will not know, we will not be able to see inside the nostril. Yes, so that whichever side the ring is present, we will know that that particular side, at that particular moment, the point of the catheter is. So here the eustachian tube catheter is something like this, that you can see the ring is here and the point is at the same direction as the ring. So what we do here is we pass it through the floor of the nostril till the posterior wall of the nasopharynx. Now when we have reached the posterior wall of nasopharynx, now we will turn the tip 90 degrees towards the medial. This here is the septum. This is the other nostril. This is one nostril. This is one nostril. This is the other nostril. I have passed through one nostril. This is the septum in between and I have taken it to the posterior pharyngeal wall. Now I will turn it 90 degrees. How do I know that I am turning it towards the septum? Yes, because when I turn, I can see that this is now pointing, the ring is pointing towards this side, so the tip will point towards this side. So I will turn it 90 degrees towards the septum and I will pull it back. I will pull it back till it hinges behind the septum and now I will rotate it 180 degrees. Yes, so 180 degrees. Now I can see that the tip is now pointing towards the opposite side, and this exactly is the area where the eustachian tube opening will be present on the lateral wall. So this opening will now can be maneuvered into the eustachian tube opening. This tip can be maneuvered into the eustachian tube opening and a polyester bag can be attached here and the pressure can be increased and it can be seen that whether the pressure is getting passed into the middle ear or not, and the tympanic membrane is popping out or not. So this is how it is done. This is what is eustachian tube catheterization. Now another test by which you can push air into the eustachian tube and you can insufflate the middle ear. This is what is a Frenzel maneuver. Frenzel. What is this Frenzel maneuver? This is the maneuver that is used in divers. In divers, we know that there are pressure changes when the divers go down and when they go up. So when there are pressure changes and the diver wants to equalize his pressure, middle ear pressure as the external pressure, what he does is he has to force air into the middle ear through the eustachian tube. Now for us, we can do the Valsalva maneuver when we are outside here. But in divers, they are already on oxygen bags, so the air that is coming from the lungs is already restricted. So now they cannot use their air of the lungs again and again and empty their lungs completely to insufflate the middle ear, just to to make the pressure of the middle ear same as external. So what they do is, they use this maneuver. In this maneuver, what they do is they raise the posterior part of the tongue. Then they close the nostril, they close the mouth tightly, and they raise the posterior part of the tongue. How do they raise that? Yes, that is by saying ka 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 with your mouth closed and with your nose closed. Try to do it. You will also be able to do it. Close your nostril, close your mouth, and the ka 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 ka. You say ka ka ka. What you will see is that the posterior part of the tongue, the base of the tongue area is getting raised up. That will create an increased pressure of air here, and that will push the air into the eustachian tube and through the eustachian tube into the middle ear. So what we have seen that there are so many ways that we can insufflate the middle ear through the eustachian tube. Now all these tests we can use in the OPD to check the eustachian tube functioning also. But out of all the tests that we have heard till now, what do you think is the best test to test the eustachian tube function? Yes, the tympanometry. Best is tympanometry. Why the tympanometry? In tympanometry, we are not doing anything externally, forcing air into the eustachian tube. So it is measuring the normal physiological function of the eustachian tube. Whether in anybody, normally also the eustachian tube is able to maintain the pressure of the middle ear or not. So we are finding out the middle ear pressure in tympanometry. So we can exactly come to know whether the middle ear pressure is same as the external ambient pressure or not. So the eustachian tube is functioning normally or not. So the best is tympanometry, and again that is asked in your exam. So now we know that if there will be any patient with hearing loss and we have localized the disease to be in the middle ear, we can exactly come to the exact diagnosis, whether it is fixity, whether it is dislocation, or whether it is fluid in the middle ear. And we have also seen what are the various other tests of eustachian tube function that we can do. The other part of impedance audiometry is stapedial reflex. Now, what is this reflex? This is a protective reflex. It protects the inner ear from noise trauma. So, whenever there is a loud noise, how loud? How much I am speaking, is your stapedial reflex getting activated? So, it has to be at least 70 to 90 decibels. So, if there is such a loud sound, it is picked up by the pinna. It goes to the external auditory canal, tympanic membrane, ossicular chain, footprint of stapes, organ of Corti, auditory pathway. Yes, now the auditory pathway senses that this is a very loud sound. It can damage the inner ear. So immediately in the auditory pathway at the level of the superior olivary complex is interconnection between the auditory pathway and the facial nerve. So through the interconnection, the stimulus comes through the facial nerve, supplies the stapedius contracts, pulls the stapes back, and the inner ear is protected from noise trauma. So let us quickly write this down first. So what happens is, whenever there is a sound, how much? At least 70 to 90 decibel, it is picked up. It goes to the external auditory canal. From there it goes to the middle ear. From there it goes to the inner ear. Yes, inner ear, that is the organ of Corti. And now it is picked up by the auditory pathway. Yes, auditory pathway at which level? Yes, that is the question of your exam. It is at the level of the superior olivary complex. This is considered as the center for stapedial reflex. Center for stapedial reflex. Okay, now from the auditory pathway, the impulses will now go at the level of the superior olivary complex. It will now go to the facial nerve. Okay, will it go to the facial nerve of one side or both the sides? So, is this a unilateral reflex or is this a bilateral reflex? Yes, it will go to the facial nerve of both the ears. So, from here, from the auditory pathway, the impulses will go to the facial nerve of both the ears. Facial nerve of both the ears. Yes. Now this will supply the stapedius. And we will have stapedial reflex. Stapedial reflex. Yes. So what we are seeing is, please note this very, very carefully. There are so many questions asked from the stapedial reflex. Yes. So what you are seeing is that this all till the auditory pathway, all this is the afferent. Yes, and this here is the efferent. This is the efferent. So if I ask you that stapedial reflex is mediated by which nerve? Stapedial reflex is mediated by afferent is 8th nerve, efferent is 7th nerve. Yes, so it is not mediated only by the 7th nerve. Only when the auditory pathway senses that there is a very loud sound, only then the efferent will get activated. So the afferent is the 8th nerve and the efferent is the 7th nerve. It is mediated by both the 8th and the 7th nerve. Okay, now second thing, you tell me, if I am giving a loud sound in the right ear, which means I am testing the right ear. When I am testing the right ear, I am testing which nerves of right ear and which nerves of left ear. If yes, in the right ear, when I am testing 8th and 7th of the right ear. Yes or no? Yes. And of the left ear, which one? Of the left is the 7th nerve. Yes. Now, many of the times you tell me that, okay, when we are giving a loud sound, the sound is loud, so it will go to the other ear also automatically. How are we testing only one ear when we are giving a loud sound? No, it is not so. When we are testing one ear, when we are giving a loud sound, suppose I am giving a loud sound, I am giving a 70 decibel sound in the right ear. What will happen when the sound goes to the left ear? During transmission in the air conduction, 40 decibel gets lost. So this 70 decibel now becomes how much after the 40 decibel is gone? Only 30 decibel sound. Will a 30 decibel sound be loud enough to elicit the stapedial reflex? No. So when I'm testing with a 70 decibel or even if I'm testing with a 90 decibel, the sound when it reaches the other ear is not loud enough to elicit the stapedial reflex from that ear also. So that is why when I am testing right ear, I am testing only the right ear. I am testing only the 8th and 7th of the right and the 7th of the left. Is that very clear? So the first thing that we need to know is what is the afferent pathway, what is the efferent pathway, which nerve is the afferent, what is the efferent. Now when I say that the afferent is the 8th nerve and efferent is the 7th nerve, So do you understand that only if there is a damage of the 8th nerve or if there is a damage of the 7th nerve, this stapedial reflex will be affected? See this pathway carefully. What we are seeing is there are so many multiple parts in this pathway. So if there is a defect anywhere in the afferent is not only the 8th nerve. Afferent is the external auditory canal, it is the middle ear, it is the organ of Corti. So there are so many parts of the afferent. So if there is a defect in any part of the afferent, any part of the interconnection, any part of the efferent, stapedial reflex will be affected, which means if in any person we are giving a sound and we are getting a normal stapedial reflex, what is that an indication of? Yes, that tells us that the complete afferent, the interconnection, the efferent, everything in this patient is normal. So that is why this is a test that is used for testing malingering. That is used for testing non-organic hearing loss. What is non-organic hearing loss? Non-organic hearing loss means that the patient does not have any organic cause of hearing loss. The patient is malingering. The patient is lying. The patient is telling that I'm not hearing, I'm totally deaf from my right ear. And when you do a stapedial reflex, it is absolutely normal. So if there is any defect in any part of the afferent, interconnection or efferent, this test will not be normal. If it is normal, it means all the parts of afferent, interconnection and efferent are normal. So which means that the patient is malingering. This is a very important test for malingering also. So let us quickly write down. Till now what we have seen is, we have seen that it is testing. This is a test which tests which nerves? Yes, it tests the 8th and the 7th nerve. What is the afferent nerve? Afferent is the 8th nerve. What is the efferent nerve? Efferent is the 7th nerve. If we are giving a loud sound in the right ear, which means if we are testing the stapedial reflex in the right ear, which nerves of the right ear we are testing? We are testing in the right ear, we are testing the 8th and the 7th of the right ear, and of the left ear we are testing only the 7th. If there is complete destruction of the 8th nerve, then stapedial reflex will be absent in which ear? Just see this. If there is a complete destruction of the 8th nerve is totally gone, completely gone. Yes. So now the stapedial reflex will be absent in which ear? Only in the right ear or only in the, or both in the right and the left ear. If the right ear 8th nerve is completely gone, it will be absent in both the ears. Why? Because if the 8th nerve is completely gone, the sound has not been picked up. So why should there be any stapedial reflex in any ear? Whereas if there is a efferent palsy, if there is a facial nerve palsy of the right ear, if there is a facial nerve palsy, stapedial reflex will be absent in which ear? Only the right ear. Yes, only in this particular ear. Only when the sound has come into the right ear, now this facial nerve will not be able to transmit the impulses. So in the right ear, stapedial reflex will be absent, whereas in the left ear it will be present. Is that very clear? So if there is 8th nerve complete destruction in the right ear, stapedial reflex will be absent in both ears. Whereas if there is a 7th nerve palsy of the right side, stapedial reflex will be absent only in the right ear. Only in the right ear. So now I told you that the stapedial reflex is a very sensitive reflex. If there is any defect anywhere in the pathway, the stapedial reflex will be absent. Yes. So if there is any defect, I told you that the conduction occurs from the middle ear and then into the inner ear and then into the auditory pathway. Yes. So let us see what will be the changes whenever there is any defect anywhere. So if there is a defect in the middle ear, that we call as conductive hearing loss. Yes. So if there is any conductive hearing loss, the stapedial reflex will be absent usually. Stapedial reflex will be absent. Why absent? Yes, if there is a conductive hearing loss, that will not allow the sound to reach, when it reaches the inner ear, to be so loud that it can elicit the stapedial reflex. So usually conditions of the middle ear like ossicular discontinuity, like ossicular fixation, like fluid in the middle ear, they lead to at least 40 decibel or more than 40 decibel, 50 decibel, 60 decibel hearing loss. So if you are giving a 70 decibel sound, when it reaches the inner ear, it will not be loud enough that the auditory pathway had to think that, yes, let me protect the inner ear from loud sound. It is not a loud sound now at all that can damage the inner ear. So now it will be absent. So that is why whenever in ossicular discontinuity, ossicular fixation, fluid in the middle ear, we get the stapedial reflex done, it will be absent. What will happen when there is any pathology of the inner ear, organ of Corti? Yes, one of the very important function of the organ of Cotta is fine tuning of loudness. It tunes the loudness. When we are hearing the sound, we are able to know how loud it is. Now the intensity has increased, the intensity has decreased. So, but if there is a defect in the organ of Cotta, if there is a sensory hearing loss, if it is a cochlear hearing loss, what will happen? This fine tuning will be gone. So this patient will have a hearing loss. When the loudness is less, he will not be able to hear the sound. But as the loudness of the sound is increased, the abnormal organ of Cotta is not able to tune the loud sounds, and it abnormally increases the loud sounds. It abnormally loudens the loud sounds. So in simple words, whenever there is a defect in the organ of Cotta, loud sounds become intolerable. Not the simple sounds, not the less loudness sounds. Which means that if there is any patient who has a defect in the organ of Cotta, what will happen? This patient, when you're talking to him normally, he will say that I'm not hearing. Why can't you speak a little louder? Yes, but the moment you increase the loudness of your voice, the patient will tell you, why are you shouting? Yes, so loud sounds abnormally increase. There is intolerance to loud sounds whenever there is a cochlear defect. Now just think that if this is what happens whenever there is a defect in the organ of Cotta, loud sounds become abnormally loud. So suppose I am expecting the stapedial reflex when I am giving a sound of 70 decibel. Yes, now in this patient who has an organ of Cotta defect, when I have given a 50 decibel sound, the defective organ of Cotta increases the 50 decibel sound to 70 decibel or maybe more than 70 decibel. So even at a loudness less than 70 decibel in this patient, I will get a stapedial reflex. So what it means is that the threshold of the stapedial reflex, the loudness at which I am getting a stapedial reflex normally, that is lowered. That is an indication that the organ of Cotta is not functioning properly. There is a defect in the fine tuning of the organ of Cotta. That is an indication of cochlear defect. So if there is an organ of Cotta defect, what will happen is that the threshold of stapedial reflex will decrease, which means we can now be able to elicit it even at a lower loudness. It is elicited at lower loudness. Now, what will happen when there is a defect in the auditory pathway in the nerve? Now, if it is completely destroyed, then you will not get any stapedial reflex. But if the destruction is not complete, if there is a retrocochlear pathology, if there is a neural pathology, but it is not so severe that there is complete destruction, then in that case, what will happen to the stapedial reflex? Yes, what will happen is that whenever there is a defect in the auditory pathway, there is a neural defect where there is a retrocochlear defect. In that case, the nerves, they get fatigued very easily. So what happens is that if I'm giving a sound continuously for a loud sound, 70 decibel sound or 80 decibel sound, continuously a loud sound for 10 seconds. In anybody's ears, if the stapedial reflex is, if the nerves are functioning normally, then the stapedial reflex will be present continuously for 10 seconds. Whereas in people in whom the nerves are not functioning properly, if there is a retrocochlear defect, then the nerves will become fatigued very quickly. So now what will happen is there will be stapedial reflex initially, and then the nerves will get fatigued. They will stop transmitting the sound. So after some time, the stapedial reflex will be absent. Whereas the stapedial reflex should be present till the loud sound is there. Its function is to protect the inner ear from noise trauma. So what will happen in defect of the nerve or the retrocochlear hearing loss? Retrocochlear hearing loss, here organ of Cotta is cochlear hearing loss. The stapedial reflex will decay. This is known as stapedial reflex decay. Stapedial reflex will decay very fast, even if the sound is continued to be given. So what we are seeing is that the stapedial reflex is a very, very sensitive test. Is it a subjective or objective test? It is a objective test. Patient's cooperation is not required, and this will tell you about each and every hearing loss. If there is a defect in middle ear, if there is a defect in inner ear, if there is a defect in the auditory pathway, if there is a palsy of the facial nerve, it will tell you everything. So this is a very, very important reflex. This is a reflex that is very commonly asked in your exam. Now, also one important thing about facial stapedial reflex is that, now suppose the stapedial reflex is, the stapedius is supplied by the facial, we know that. Okay. Now, suppose the stapedial reflex is absent in any patient of facial nerve palsy. There is a patient who has a facial nerve palsy of the right side. So, stapedial reflex will be absent in the right ear, that we have already seen. So, if the stapedial reflex is absent in the right ear, can you tell what the site of lesion of the facial nerve palsy is? Yes, will it be the tympanic segment or will it be the vertical segment? Will the injury be before the nerve supply, before the fibers of the the supply of the stapedius, or after it? Yes, it will be before it. If the injury is here, stapedial reflex will be absent. So it also tells you about the site of injury of facial nerve palsy. So let us quickly see where all we do this test. So let us quickly see where we do the stapedial reflex. Yes, you are going to tell me this now. I have already told you all this. Yes, in conductive hearing loss, the stapedial reflex will be, yes, it will be absent. In sensory hearing loss, what will happen to the stapedial reflex? In cochlear hearing loss, yes, the fine tuning will be gone. So loud sounds will become abnormally loud. It will be elicited even by a 50 decibel sound, whereas it should be elicited at 70 decibel. So threshold is reduced. In neural hearing loss, retrocochlear hearing loss, yes, there is an abnormal fast decay. So the stapedial reflex decays. Can it be used for malingering? Yes, it can be used for malingering, though this is not the best test for malingering. The best is BERA. When we do BERA, we will see that is the best test. But yes, there is a very important test for malingering. And can it tell you the site of facial palsy? Yes, if in any patient there of facial nerve palsy, stapedial reflex is absent, where is the site of lesion? It is before the branches of the stapedial reflex, before the branches of the facial that supply the stapedius. So that is the horizontal segment. So this is all you needed to know in stapedial reflex. So I hope you have understood this. Quickly do all your questions.